Welcome. I'm Jim Shea with the Acoustic Neuroma Association, and we're happy to have you join us for today's ANAwareness Week webinar, Rehabilitation of Cranial Nerves After Acoustic Neuroma Surgery, featuring the expert team from Mount Sinai. We'll get to introductions in just a moment and then begin the discussion. But first, a few quick notes to help you get the most out of today's session. If you're watching on Zoom and have a question during the presentation, simply drop it into the Q&A box at the bottom of your screen. Captions are available for this presentation. Those can also be enabled at the bottom of your Zoom window. This session is being recorded. You'll be able to find it shortly in our webinar library at anausa.org, along with many other helpful resources. There's a great search function there to help you find exactly what you need, especially with all that we've been adding during this ANAwareness Week. While you're online, be sure to follow us on Facebook, Instagram, and LinkedIn. You'll find updates on new resources, upcoming events, and ways to stay engaged with the AN community. We're here to support you every step of the way, and we're happy to have you with us. Now let's get started. Doctors, I hand it over to you to introduce yourselves.
Good morning, afternoon, everyone. I'm Dr. George Wana from Mount Sinai Acoustic Neuroma Skull-based team in New York City. And thank you for listening to us today.
Great. I'm Zachary Schwam. Nice to meet you, also from Mount Sinai.
Hi, everyone. I'm Enrique Perez, also Mount Sinai Neurotology.
Mara Cosetti, thanks for being with us today, Mount Sinai Neurotology.
Great. So I'm going to lead off. So our talk, the four of us are going to split it. Our talk is called The Rehabilitation of Cranial Nerves After Acoustic Neuroma Surgery. Many of these cranial nerves are located just adjacent to the acoustic neuroma or vestibular schwannoma, and it's important for patients to be aware of some of the relevant anatomy and some of the relevant issues that can come up with larger or more complex surgery. So this is our group here at Mount Sinai. This is the neurotology division. We've got Dr. Wana, Cassetti, Perez, and myself. So I'm going to be going over some basic anatomy just to set the framework. So to give people just a little bit of an overview, so this is the external ear. This is the right side. This is the ear canal, the eardrum, the three hearing bones or ossicles, the inner ear, and this is all far more superficial than where the acoustic neuromas live, which is this kind of blue outline. So the nerves, the hearing and balance nerve, as well as the facial nerve, travel in a bony tunnel between the inner ear and the brainstem. And that's where acoustic neuromas will often start to grow. And as they grow, they will commonly grow towards the brain and potentially push on the brainstem. So just to give you a little bit of an overall understanding of where these lie. Looking from the other side, so this is the bony tunnel from where the brain lives. So we're looking kind of from the brain, from the back of the head, and we're looking, this is what one would see if you're doing surgery through a retrosigmoid approach. So this is towards the top of the head, this is towards the bottom of the head, this is towards the inner ear, and this is the brainstem. So the cranial nerves are special nerves that come directly off the brainstem, and they're all labeled with numbers. So they go from 1 through 12, and a lot of them are not necessarily relevant to acoustic neuroma surgery, so we don't mention them. We're going to start at number 5. So number 5, this one right here, this bigger one, is called the trigeminal nerve, and it provides sensation to the same side of the face. So if this is a left side, this provides sensation to the entire left side of the face. The abducens nerve, or number 6, is not really shown here. It'll be shown on a later slide, but it's kind of behind this nerve bundle here on the other side, and it moves the eye that's on your same side away from your nose. So if it's a left side, and you want to look towards your left, it moves your left eye away from your nose. The facial nerve is number 7, so this is an important one for acoustic neuroma surgery, and Dr. Wana will be talking about that. So this is responsible for facial expressions, blinking, eye closure. It produces tears. It plays an important role in producing saliva, in certain glands, and it does also have an important function with respect to taste. Number 8, the vestibulocochlear nerve is also incredibly important, and this is the nerve that the acoustic neuromas or vestibular schwannomas will grow off of. So most of what we focus on with respect to vestibular schwannomas is kind of dead center here. So this tunnel, the internal auditory canal or IAC, and this area here. But because some acoustic neuromas can become quite large, it can also affect nerves higher as well as lower. So just to keep going here, so we're going to talk about these nerves now. So the lower cranial nerves are 9, 10, 11, and 12. So 9 is called the glossopharyngeal. It does sensation to the back of the throat, swallowing, and it does play a role in taste and saliva production. 10 is the vagus, which is very important. It does movement of the vocal cords, it helps with swallowing, digestion, and it does play a role in controlling your heart rate. 11 is the spinal accessory nerve, and it moves the sternocleidomastoid, which is this muscle here in your neck that moves your head side to side, and it also will move the trapezius, which is the muscle in the back, where if you're doing a shoulder shrug, that's what that moves. And finally, number 12, which is not shown here, but it's right in front of these on the other side. That's the hypoglossal nerve, and that moves the tongue. So this is a picture or diagram of a few different acoustic neuromas, and we're looking from the top here. So this is the bony tunnel or internal auditory canal. This is the inner ear. This is the brainstem. So this is like a medium-sized tumor, and you can see as it grows, it often grows towards the brainstem and can cause a fair amount of compression, sometimes quite a bit of compression, and it can also affect and push certain nerves. So before surgery, even though tumors will press on and stretch various nerves in the brainstem, nerve problems, with a few exceptions, are uncommon. Many patients will have hearing loss and balance issues from the growth on the 8th nerve, and some patients with large tumors may have facial numbness or tingling from pressing on the 5th nerve or the trigeminal nerve, this yellow one. After surgery, problems with nerve function, with some exceptions, are uncommon. So many times if there are nerve problems, they are usually temporary and they gradually recover over several weeks to several months. Patients with larger tumors who are undergoing surgery are at higher risk of nerve problems. So Dr. Perez is going to be talking about some of the nerve problems, and I'm going to be moving the slides along.
Okay. Hi, everyone. So yeah, to continue following Dr. Schwamm's description, as you recall, the trigeminal nerve, because of its proximity to this area, can be involved in the symptomatology that patients experience, both preoperatively and postoperatively. Usually when we see it preoperatively, we immediately raises a little bit of a red flag that we're dealing with a larger tumor because, to get to that area, the tumor needs to grow superiorly quite a bit. And when we talk about trigeminal dysfunction, it really comes in different flavors, right? So as Dr. Schwamm was mentioning, you could have numbness, which we call hypoesthesias, essentially along the forehead, cheek, and like lip area on the same side as the tumor. You could have paresthesias, which is essentially an discomfort in the face, can be described as tingling or pins and needles sensation, or actual pain, which is really trigeminal neuralgia, is what we call that. And another important sensory function of this nerve is that it actually gives sensation to the cornea. So that's actually quite important, because when a person has lost the sensation of the cornea, they may scratch their eye without noticing in the middle of the night. and lead to a corneal abrasion, which is something that needs to be taken care of by an ophthalmologist fairly quickly. There's another function of this nerve that's more of a motor function. It gives movement to muscles of mastication, so for chewing. It's a little bit rare for patients who have symptoms of this, but usually feeling like a locked jaw or spasms in the muscles. So as Dr. Schwalm was mentioning, the trigeminal nerve, if you end up with symptoms of trigeminal dysfunction after surgery, luckily, by far, these tend to be transient. It's a pretty hardy nerve, and it does, recover over time. And the more common are numbness and, these tingling sensations, which are a little bit more tolerated by patients. There are a subset of patients that unfortunately do develop pain afterwards, and pretty rare, but there's some that the pain persists. So they require more active management. And so for trigeminal neuralgia, the treatments are essentially regardless of what the cause is, whether it's from surgery or even patients who undergo radiation can sometimes end up developing neuralgia afterwards. Pretty rare, but it can happen. And so the treatment starts as an algorithm. So you start with the least invasive, which is just trying to give medications such as anti-epileptics like carbamazepine or gabapentin, or migraine medication like nortriptyline, or even antidepressants. Should the symptoms persist, that's where, of course, you need a more multidisciplinary approach to try to treat these patients. You may involve a neurologist, a pain specialist, and even a neurosurgeon, as there are more invasive treatment options for chronic trigeminal neuralgia that may require even radiating the nerve, for instance, to try to get rid of whatever remaining function there is. Again, take home, luckily, this is pretty rare, happens only about 3 to 5% of patients postoperatively. For the abducens nerve, cranial nerve 6, as Dr. Schwalm was mentioning, this is having symptoms of abducens dysfunction is even more rare. You do require a fairly large tumor that compresses against the brainstem where this nerve usually sits, as you can see in the anatomy here. It's interesting to note as well that if you see a patient that comes in to begin with dysfunction of their abducens nerve, which, as you can see in this photograph, it's really described as diplopia and having double vision because, you can't move your eye away from your nose laterally, as you can see in this patient here. I'm not sure if you could make it out easily here, but it's the right eye that has the problem, right? So they can't move that eye towards the ear. And so if you see a patient preoperatively that has this, that should raise a red flag. I mean, either it's a pretty large tumor that's compressing on the nerve, or maybe even causing hydrocephalus and pressure intracranially, because the natural course of this nerve predisposes it to dysfunction if there's elevated pressures in the skull. But again, luckily that's quite rare unless you have a fairly large tumor. Like trigeminal dysfunction postoperatively, having abducens dysfunction postoperatively, it's rare, but also most cases temporary. And so we usually just manage it conservatively. It could be quite disturbing for patients to feel like they're seeing double vision. And so putting an eye patch can help for that. In some cases, ophthalmologists will prescribe prism lenses, which can align your visual field temporarily. And in very, very rare cases where the nerve is not recovering, there are some surgical procedures that neuro-ophthalmologists can do to try to align the eyes a little bit better to relieve the discomfort from the double vision.
Great. Thanks, Enrique. I just want to comment that I got this video off of YouTube because I thought it was a great illustration. The University of Michigan Ophthalmology Department had a very good one. So this is not a patient with an acoustic neuroma, but this is a very clear example of what that might look like in its worst case. Okay, Dr. Juana is going to be talking about facial weakness and the role, of facial monitoring and how we deal with the facial nerve during surgery.
Thank you, Zach. Thank you, Enrique. So the facial nerve, or what probably all the acoustic neuroma patients will be asking about during consult for surgery is a very high value nerve also, because it's making people smile, closing their eyes, frowning, give taste to 2/3 of the tongue, and then some tear and sometimes saliva production. Unfortunately, because of the relationship of the facial nerve and the vestibular nerve, and that's Dr. Schwamm mentioned it earlier in the slide, the facial nerve is always at risk in acoustic neuroma surgery. And as you can see on the slide, the facial nerve comes from the brainstem and it enters into the internal auditory canal, which is the tube Dr. Schwamm is putting at, the arrow, where the vestibular nerve and the acoustic neuroma are in the same canal. So, and then after that, it goes to the middle ear, and then from the middle ear, it will leave through the neck. And as you can see, it gives the upper and lower branches of the facial functions. That's why people smile and close their eyes are innervated by that nerve. So when the tumor is small, the risk on the nerve usually is, as everybody expected, will be low, because you'll be able to see the nerve at the source of this brainstem. It will be pushed like a U shape, and you can see it distally, which is toward the inner ear. So technically, you'll be able to see the nerve on both ends of the tumor and dissect the tumor very safely. As the tumor grow bigger, the nerve gonna be pushed against the wall and against the brainstem and become very thin with time. And that will put the nerve, as you can see in the last picture, as the fibers at the risk to be injured during dissection, especially in cases where there is splay on the top of the nerve. And you can see on this picture that the nerve is in front. This is where we're pointing at, is in front the vestibular nerves and the cochlear nerves, and that's where it gets splayed too much. If the tumor is big, it can be at risk. The direction of the nerve sometimes is very tricky, and with experienced team and surgeon, they can earlier identify where the area is at risk, and that's why, for example, in that case, you can see that the nerve is making a very U-shaped turn. So if you're thinking it is going to be straight line, it's not going to be straight line, and it can be injured in that occasion. So that's why in many cases, it's extremely important over time. And that's, I will tell you that after over 20 years, in the past, we used to be very aggressive on those tumors, try to take every single bit of them. And because of that, as you can see in that picture, some fibers can be very, very retracted when you try to pull the last piece of tumor, and the nerve can be very weak. Over many years and over the decade now, we realize that it's okay to leave. This is a benign tumor. It's not going to kill the patient. If you take the majority of the tumor and you left the sliver, well, that's what patients hear sometimes from their surgeon, in order to protect the nerve. This is not a bad way of practicing, because these tumors, most of them don't grow. And if they grow, you can always address them with radiation, but you preserve the function of the facial nerve. So during the surgery, a lot of monitors will be placed on the patient. There'll be monitoring for the facial nerve, the swallowing nerve, there'll be monitoring of the motor function, sensitive function. And these are very, very important, and also monitor for the hearing. Because if you're doing hearing preservation, you want to make sure that there's no pressure on the hearing nerve and you're going to hear it ahead of time. For the facial nerve, if the tumor is super big, the facial nerve monitor will help you to at least find an area where the nerve is close to dissection, where the nerve monitor will be going off. And sometimes when you start to do a lot of these surgery, you realize sometimes that the picture that Dr. Schwamm is pointing at is not always the perfect picture, because sometimes I've seen it, and people who have in our center seen it, that the nerve run on the top of the tumor, which is very, very unusual. And then the minute you open the dura or you open the bone and try the translab or trying to get on the tumor, the facial nerve is the first thing you see. It's very rare. It can happen. But if you are in a center where they have a busy number of those cases, I'm pretty sure many centers around the country has faced that. And it's important to be prudent initially when you start, to make sure that your nerve is not running on the top of the tumor. So what will happen usually? Usually the facial nerve is, as the tumor are small, as I said before, it will be easy to identify. When the tumor are very, very large, The nerve sometimes can be very difficult to identify, and sometimes it's not, but it's not always easy way to find it. So you just have to be careful when you dissect, use the neural monitor. And as I said before, if you need to leave a small piece or a sliver in order to maintain a perfect nerve function, that's okay to do. At the end of the case, and you're going to hear it whether you are at Sinai or in another center, that all the surgeons who do those surgery will tell you that we stimulate the nerve. If some people are listening to that, they're probably going to hear that, or they hear it from me. And we stimulate the nerve at the end of the surgery, and the nerve was stimulating fine, which is, in general, it's a good answer for the nerve function if the patient wake up weak, because when we stimulate at very low dose of electricity will tell us the nerve is intact in its anatomy. So generally speaking, and that's in general, large tumor at higher risk. And when we say over what centimeter, people ask, usually the data is over 2 to 2.5 centimeters. The facial nerve is at higher risk than when the tumor is less than 2 centimeters. When you look at the data all over the world, usually they talk about all tumor in large and medium in around 75%. This is not the number that you're going to hear from Sinai and high volume centers. Usually it's around over 90% for facial nerve function that is preserved in high and busy academic centers. But if these things happen, if you operate, and we told our fellows, our residents, if you're going to have surgery, there is always going to be risk. The only time you will have zero risk if you don't operate, and this is not the case. So if this has happened and you know the nerve is going to be working or not, or if there is weakness after the surgery, it's very important to protect the eye. Because if you get an eye injury, which is for the cornea, because it's always dry, and you don't lubricate a lot, that can lead to blindness. So we are very, very aggressive on the eye care if there is weakness on the facial nerve very, very early after surgery. Whether we decided to go for gold weight or just weight, that depends on the nerve function that we find and how much tone in that eye. But regardless what approach we'll take for the eye, it's always an approach that's going to make us feel good that we minimize any risk of corneal injury. And for any synkinesis or any down the road issues, Botox and other cutting nerve selectively you can do. If we have a complete nerve dysfunction completely and paralysis and it's not going to come back, we do have a very good facial reanimation team at Sinai. They're really expert in facial reanimation, and then we can always give you their website. You can see about some of their patients' outcome. They are very, very good, and that's the route we will take early if we feel that the nerve is not going to coming back. We heard a lot about electrical stimulation. We don't recommend that. I think many centers around the country will agree that it's really not recommended. And with that, thank you for listening, and I will pass it to Dr. Cossetti.
Thank you. Thanks a lot. Okay, great. So I'm going to be talking about hearing loss. And as you can tell from this diagram, and perhaps from Dr. Schwam's presentation as well, surgeons love anatomy. So we just love talking to you about anatomy. And so this hearing loss talk is going to be a lot about anatomy and then a lot about personalizing what your particular hearing situation is. So Dr. Schwam, you can click the button again. Hearing loss can occur, and this is going through the hearing loss pathway through the canal, the eardrum, all of the little bones, and the cochlea that Dr. Schwam mentioned earlier, and then back through the nerve of hearing to the brainstem. And of course, that's where an acoustic neuroma can occur. Now, it's important to remember that actually hearing loss can occur throughout that entire pathway, and there are a bunch of different hearing options that are based on where the hearing loss occurs and also the type of hearing loss. So hearing loss that you get with an acoustic neuroma is typically on one side. Now, every patient is different, and we're always looking at both ears of the patient, both when we're thinking about the treatment options, and then, of course, when we're thinking about how to deal with any hearing loss that the tumor itself may have caused or that occur after surgery. So in this case, with acoustic neuroma, we're talking about individuals with hearing loss in one ear, the ear with the acoustic neuroma. Now, many individuals in that situation can function. You might not look at them, or you might not be able to tell from their speech that they have hearing loss because they're hearing from their other ear. The problems that people with hearing loss in only one ear have primarily center around localization. So they often may have difficult time telling where a sound is coming from. For example, if their phone's ringing, they wouldn't know if it's coming from the kitchen or from another place in the house, or if someone's calling their name. And the other difficulty is when there's background noise. Now, truth be told, there's lots of places where there's background noise. I think most of us live our lives in background noise, so that can be a significant barrier. This slide is supposed to give the idea, and the intention here is talking about all the many factors that go into how we talk about hearing loss, how we decide about treatment options, and how we decide on how to rehabilitate that. And in the small box on the right, you can read the writing there, which says tumor size and hearing level do not always go together. And boy, that is just not obvious. You would think that someone with a very large tumor would have complete deafness, and someone with a tiny tumor would be able to hear fine. And in fact, that relationship is just not there. And that level of data has been well known for a long time. So that gives just a little bit of insight in how we have to think about different size tumors, how we have to think about the hearing before surgery and the hearing afterward. So obviously, tumor size is something that we take into account. Preoperative hearing level, so how well someone's hearing before surgery. There are definitely patients, perhaps on this call, or definitely ones that our team meets all the time, that actually come to discover they have an acoustic neuroma from hearing loss. And so, in fact, many people present or have hearing loss already before even any treatment has occurred. There can be situations where people have tumors in both ears. That's typically called neurofibromatosis type 2, and that can have variable presentations, but often both ears are affected. And there can be other different preferences or experiences from the patient that can help us figure out what the treatment is. So in each of these treatments, and we're not going to go through them because we're really focused on the cranial nerves in this particular presentation, but sometimes acoustic neuroma patients will observe those patients, especially if that tumor is not demonstrating significant growth. They can undergo surgery, which is definitely a lot of what we've discussed in this particular webinar so far. They could undergo radiotherapy or radiosurgery by either Gamma Knife or Linac or CyberKnife, one of those options. And then there's some other evolving treatments as well, such as Avastin, which are here on this slide. Now, in all of those cases, when we want to look at the patient's hearing after surgery, we have a couple different scenarios. And this can be kind of complicated, so I actually like to go through it and describe the options as we think about the different scenarios. So you could have stable hearing if you're observing and there's no decline in hearing. And typically we do monitor people both with MRIs and with audiograms to tell. Or you could have surgery and have preservation of hearing. Dr. Wana went into some of that. We do extensive monitoring at Mount Sinai, and most of the high volume centers are doing intraoperative monitoring of hearing, and that's really crucial for us to be able to maximize what's going on. You could have decreased hearing, and in fact, you can have decreased hearing after any treatment option. Your hearing could go down just by observing the tumor, it could go down after surgery, and it could go down with radiation treatment as well. And depending on how much it goes down, a hearing aid may be an option. Typically, there are different levels that we use on an audiogram that measures both level of hearing as well as the clarity of how you're understanding speech that helps us to understand if a hearing aid is an option. Patients often ask us lots of questions about hearing aids, and I think on the next slide, this was actually from a little bit ago, but this is just one picture of all the hearing aid options out there. People often will ask us, I want the best one, or the one that's the best for me. And in fact, it's very personalized. One of the things that's really interesting about acoustic neuroma management or treatment, and why we have a whole team, is also because we really try to individualize the treatment for every patient. So how do you know what's the best or what's the right hearing aid or treatment for you? Well, we rely on our audiology colleagues, and we refer and work very closely with them that help to understand both if a hearing aid is appropriate and, of course, which type might be the case. Now, there's a bunch of treatments and caveats with hearing aids, such as insurance, which I'm not going to go into detail with, but suffice to say, it's really good to have a team to advise you about that. Okay, so the next scenario might be if there's no hearing. And in fact, it's possible to have no hearing both even before surgery. Sometimes with a small tumor or a large tumor, there might not be an option for hearing. And in that case, if you have hearing loss in only one ear, that's referred to as single-sided deafness typically. And there are multiple options for that. So I'm going to go into it. When you have hearing loss in one ear, you could have hearing loss with an intact nerve. You could have an intact nerve because you didn't you didn't operate on it, or you could have no nerve, and often that's the case in very large tumors. Lots of options in the case of single-sided deafness. Here's a list of them here. And in the next slide, we're going to go over sort of the three major categories. So the three major categories of treatment for this include options that send sound to the good ear. So Zach, maybe you could go to the next one just for a sec. Thank you so much. So there's a type of hearing aid called a cross hearing aid. That's on the far left of this screen here. That is not a surgical option. It's a hearing aid, and you wear a receiver or transmitter on one ear and a hearing aid on the other ear, and it sends sound from the ear that can't hear to the other ear. So in fact, you're getting access to the environment. You're getting access to people talking to you on that side, but you're actually hearing it in the other ear. One of the best examples of this, I think, is like for Uber drivers or other drivers. If someone's talking to them if their good ear is to the roadside, someone talking to them in their deaf ear is actually quite helpful. So it actually routes the sound to their good ear. Now, there's another option to do that where you don't have to wear a receiver in the deaf ear, and that's called a bone conduction hearing aid. These, and I'll show you in a slide or two, can be both surgical and non-surgical. They also transfer sound to the good ear, and they do so through the bone. That's why it's called bone conduction. Now, the last category, this is something totally different. This does not route sound to the good ear. This is involving only the ear that can't hear, only the ear with hearing loss. And a cochlear implant is implanted into the ear with hearing loss, into the ear with the acoustic neuroma, and allows you to hear from that side. So this is actually a picture here of the multitude of options for that middle category. I grouped it all together in the last slide, but there are a lot of options. Some of them are surgically implanted. Some of them are non-surgical that you can wear on a headband. For us and our team, we have a whole process where you can go and try that, which will really help you understand if that's the right treatment for you. So cochlear implants occur when a hearing aid isn't effective, so you can't just increase the volume to get better hearing, and it requires an intact or a present cochlear nerve. That would occur if you're choosing observation with an acoustic neuroma, if you've gone with radiosurgery, or if you've gone with microsurgical resection with good intraoperative monitoring or other things where the nerve remains intact. And this is kind of a new thing where we're doing cochlear implants for individuals with acoustic neuromas. The cochlear implant goes into the area of the cochlea, so it actually provides electrical stimulation to the inner ear, which is then carried along that nerve that has the acoustic neuroma, and that's why you have to have an intact cochlear nerve for that. We've had some data, and there have been some nice studies. I won't go into great detail about this particular research study, but it suffices to say that the data showing that cochlear implants work in those cases that I mentioned is quite robust. So in fact, it might be an option for an individual in certain circumstances with pretty good outcome. One last caveat I might mention is that in some situations, insurance is important. I mentioned insurance related to hearing aids. There's always insurance in fact related to cochlear implants as well, and specifically with Medicare. So there are a multitude of factors that really help us understand what options might be right for a given individual. The last thing that I'll mention is something. So if you don't have a cochlear nerve, as we discussed, there are some additional options that I mentioned. In fact, a cochlear implant wouldn't be an option for you, but something that transfers sound to the good ear, either across a bone anchored device or a bone conduction device. And then the last thing is something I hadn't mentioned, which is an auditory brainstem implant. And in fact, these are currently approved for individuals with neurofibromatosis type 2 and some other situations. And I mention it only to bring it up to you to say that this is something that you might read on various forums or, just on the internet, or your doctor might speak to you about, but it's a pretty unique device. And in fact, we know that outcomes with a cochlear implant are actually a lot more superior to this one. So I mention it more or less just to be complete, but it's not an option we often find recommending for patients. Thanks. Well, I'm going to turn it back to Dr. Perez.
All right, guys. So next, we're just going to briefly talk about balance, swallow, and speech and voice disorders. So imbalance or dizziness in general is obviously one of the main symptoms that we think about in patients with vestibular traumas. Luckily, before intervention at presentation, it's not usually a major symptom like hearing loss and ringing. But after surgery, what I like to tell my patients is that essentially just about every patient that undergoes vestibular trauma surgery should expect some level of dizziness immediately postoperatively. And again, when we talk about dizziness, really what we're describing is mostly a sensation of imbalance, disequilibrium, more so than actual like acute vertigo attack, like feeling like everything is constantly spinning. You may have a little bit of that initially, but what most patients describe as issues with ambulating, imbalance, getting out of bed, etc. And it all makes perfect sense, right? We described that these tumors are essentially growing from the nerve of balance, the eighth cranial nerve. And so if you can imagine, we're essentially resecting that area. So it's expected that you're going to acutely stop whatever residual function you're receiving from that side. And that's where there's a whole process we call compensation, where your brain, the centers for balance in your brain, require some time to compensate for that loss of function that happened acutely during the surgery. Luckily, in the vast majority of cases, patients are able to compensate fairly well over time, essentially by using their contralateral better ear. And in not too uncommonly, we'll send patients as well for some vestibular therapy after surgery to try to expedite some of that compensating process. Now, some key things to think about that, I counsel my patients on. There are certain factors that play a role in, whether their patients are at higher risk for prolonged imbalance issues. So we always discuss age. Of course, the older you are, you may have already at baseline some balance dysfunction, even on your better ear. So that may delay the compensation process. Also, patients who suffer from migraine disorder. That's another key thing to discuss. It's been described that those patients tend to have a little bit more prolonged phase of dealing with dizziness issues than others that don't have a clear history of migraine disorder. And finally, just tumor size is another thing to consider. If you could think about it, if you have a fairly small tumor, you could imagine that a lot of those patients may still have some significant residual function, and you're acutely removing all of that. Versus somebody who has a larger tumor may have less function there to be removed. So they may actually compensate, ironically, faster sometimes than somebody with a smaller lesion that gets removed. And then, yes, finally, moving on to the lower cranial nerves of cranial nerve 9 and 10. As Dr. Schwam described at the beginning of the lecture with the anatomy slides, similar to the trigeminal nerve, having dysfunction in these nerves postoperatively is quite rare because it really does require fairly large tumor extending inferiorly to come close to the vicinity of where those nerves exit the skull. Another potential problem that can occur, of course, that's more catastrophic is if a patient for whatever reason incurs an ischemic or like a stroke, essentially an injury to the brainstem in the area where those nerves take off, which could cause significant dysfunction postoperatively. Again, luckily, this is quite rare, mostly seen in very large tumors. In fact, as Dr. Wana described during his part of the lecture, we have means of monitoring these lower cranial nerves as well. If we know ahead of time that, we're dealing with a large tumor, we have ways to monitor that and try to, help us preserve these nerves. And so what can be done in terms of dealing with dysfunction after injury from these nerves? So remember that cranial nerve 10 is perhaps the most important cranial nerve in your body. It essentially does a bunch of functions, but one of the key functions are, moving your vocal cords, so for your voice, and then helping you swallow. And so patients will usually describe having some hoarseness if they get a paralyzed vocal cord on the side of the operation, or they have some difficulty in swallowing. Usually, difficulty in swallowing that's significant requires not just cranial nerve 10 injury, but also 9. So it's a combination of these two nerves that are very important both for swallowing function. And so we deal with this in many ways. Usually in a center like this in Mount Sinai, as was described earlier, we have a multidisciplinary approach using our speech pathologist, our laryngologist, to try to improve patients' ability to swallow and speak. And so there's different ways we can modify the diet to prevent aspiration, because that's the main concern that we have with these patients. We don't want them to get a pneumonia from aspirating food when they're eating. And if just simple conservative measures such as modifying diet and swallowing exercises are not sufficient, there are procedures that can be done by our laryngologist to try to move the vocal cords through injections, or even permanent procedures to medialize them and tighten up the back of the throat to be able to swallow a little bit more effectively. In the worst case scenario, of course, if a patient continues to have aspiration risk, they will need to undergo insertion of a gastrostomy tube so that they could feed themselves without having to risk having an aspiration.
Okay, thank you, Enrique. And a few more nerves that are also very uncommonly affected, but just for the sake of being comprehensive, we can discuss them. So the accessory nerve, the 11th one again, provides power to the SCM, or sternocleidomastoid muscle. That's the one that kind of turns the head, and the trapezius, which will go to the shoulder and help you do shrugs. Problems just like 9 and 10 are very uncommon. You usually see it with other pathology. But if for whatever reason there's an issue with it, you can have some decreased shoulder strength. And the good news is it's usually compensated for by other muscles, and it's usually very easily treated with physical therapy. And again, the 11th nerve is all the way down here, and it's often way away from the tumor, although very large ones can certainly cause some issues. The last one is number 12, or the hypoglossal nerve. It allows for motion of the tongue. Again, problems are very uncommon because the 12th nerve is very low, and it's even farther away from the main event. It's in front of 9, 10, 11. So problems are very uncommon. You can have issues with articulating your words, and rehabilitating it is usually done in close coordination with a speech and swallow therapist. This is a representative case. This is not somebody with an acoustic neuroma. This is somebody with a very different kind of tumor. And I want you to look at the left side of the tongue. You can see it doesn't look the same. And when she sticks her tongue out, the tongue goes off to the other side. So that's from not having electrical innervation of the muscles. Okay, so I know that was very comprehensive. It's a lot of the things that we discussed were, very uncommon or rare for the vast majority of patients, but we just wanted to give everybody a nice comprehensive overview of any of the nerve-related problems. So Dr. Cassetti and Dr. Wana's portions were, about hearing loss and facial nerve issues are usually the most pressing for people, and it's what we talk about the most. Thank you.
Great. Thank you all. That was very comprehensive. I think Dr. Schwam said that at the very end. You covered a lot of areas. We have just a few minutes for some questions. We've got one patient who is 1 year post-retrosigmoid with a 1.7 meter tumor. They still have severe head pain. How would this patient know if it is nerve entrapment, and how do they manage that?
Yeah, I was going to mention something about that briefly. I mean, it sounds to me, as I mentioned at the beginning of my portion, 1.7 centimeter does not seem like a large enough tumor to really cause much trigeminal issues whatsoever, as we discussed. And so when we think about nerve entrapment, perhaps what they may have come across is whether there's something, some scar or something pushing on that trigeminal nerve. So I don't think probably in this particular case the pain may be from that, but rather just from the surgery itself. And unfortunately, there are some reports, retrosigmoids in particular, that approach can lead to issues with pain and headaches postoperatively, sometimes nerve-related pain. And if it's been 1 year out, by far, we would at this point be working together in a more, like I mentioned, multidisciplinary fashion with pain specialists, to be quite honest, to determine whether there's nerve blocks that need to be done, certain types of pain medications that can be used alternatively if whatever has been done is not working. But simply with postoperative imaging, you can look and see is there something else going on that can be causing some sort of inflammation of the nerve. So I'm sure they would have noticed it by now.
So just a couple to add on that, Jim, for that patient, it's important to rule out migraine. Sometimes that can be there for people and will not go away. I have a few patients like that have some neck issues, and when you do the retrosig, you sometimes cut into that area, so they can explore injection around the occipital nerve in the back, and they see if they have a relief, then they get their answer on that. And then I personally have, Dr. Cossetti have, and everybody has a couple of those patients that we send them, and Dr. Perez for injection if this is the case. But migraine is very important to rule out. If they have it before, it's probably something that is continued. So.
Okay. We have another patient who reports facial weakness after surgery. At what point should they seek facial reanimation?
Who's gonna take that? So I probably don't want to talk a lot on this, but if the nerve is not gonna come back as soon as possible, because you can get a fantastic result with the expert facial reanimation team very, very early, whether they move muscle and nerve transfer. Really, the results are outstanding if you know that the nerve is not gonna coming back. The surgeon will be able to tell if the nerve is not going to come back during surgery. Sometimes it's a facial tumor, so that's an easy call. And sometimes that this nerve is so stretched that it's not going to come back. If the nerve you stimulate, as I said, at low electrical level, and when I say low, we stimulate up to 0.01, which is extremely low. And if you are at around lower stimulation and you know that the nerve is still functioning, this nerve is going to come back. In our experience, all of them did come back. Then the question will be to protect the eye until the nerve come back with gold weight or eye lubricant. Now, if you know that the nerve might not come back or might, and then that's if she's asking about that type of nerve, within 6 months, if you start the animation, they get the best outcome.
Okay.
Okay.
All right. We have another patient reporting a small tumor. They have a better chance of retaining hearing via surgery or radiation.
I can answer that. So most of it actually depends on your hearing status now. So people who are diagnosed with some degree of hearing loss are at higher risk of having hearing loss regardless of what you do. So people with perfect hearing and perfect word discrimination, so meaning, when your graph part is good, near perfect or perfect, and your word understanding score is very high or perfect, you have the best chance of retaining the hearing. You're basically trading upfront versus delayed risk with respect to the hearing loss. So with surgery, there's a higher upfront hearing loss, and you generally know what your result is going to be immediately post-op or within a few weeks. Radiation, while the initial data are quite good, they'll say the hearing preservation rates are really high. If you look at those people out to about 10 years, the risk of losing your hearing out to about 10 years is actually quite high. And it usually depends on your level of hearing at the time of diagnosis. For really small tumors, we usually don't do anything unless they're growing. If you have a small growing tumor, if you have a small growing tumor and you're able to preserve the hearing and it peels out really nicely while you're doing surgery and you can preserve the hearing, then it's great. It's very hard to predict hearing preservation in the setting of surgery, no matter how good you are, no matter if you've done 5 or 5,000 acoustic neuromas. It's sometimes the nerves can be very sensitive. So, while we quote generalized rates, everyone's different.
All right. We have a patient who has had middle fossa resection 6.5 years ago and lost hearing on the affected side, but the cochlear nerve is intact. They have recurrent tumor, 10 millimeters, and they're waiting to see what to do next. They're talking about getting a cochlear implant, and might be the best option for treating is recurrent T in radiosurgery. Would my prior surgery have any scarring that would not allow me to have a cochlear implant? And what effect would radiation have on the cochlear implant?
That's a great question. I'll take that one. I think it illustrates a couple of things, which is a lot of this is very individualized. So you bring up, a lot of different aspects there. To specifically answer your question about would there be any scarring that would prevent a cochlear implant? That's an excellent question. Typically, no. If the cochlear nerve is intact, the cochlear implant actually goes in the cochlea, which is typically unaffected by vestibular schwannoma surgery in a middle fossa approach. So the general idea is that there wouldn't be any immediate dental risk. However, we use imaging to help decide that. Obviously, you've had some scans because they identified that tumor. We use the fluid signal inside the cochlea and some specific aspects of the MRI to help us understand if there's going to be anything in your particular case that might affect, such as scarring or ossification or something inside the cochlea. That one study I put up there for, I think, about 0.5 seconds did show that definitely patients who have had radiotherapy for the acoustic neuroma can have good outcomes with a cochlear implant. Hearing with a cochlear implant is not normal, but it is can give you improved localization, some improved hearing in noise, and some improvement in speech clarity. So it's sometimes hard to predict, but it is often, if there is no hearing, often a better option and has good data in radiation.
Okay. The next question, we're getting this question more and more. It's a patient who wants to know, would they need to go back for an additional surgery for a cochlear implant, or can it be done during the initial AN surgery?
So I can take that one. So it can definitely be done during the time of operation, and it can also be done at a later date. So if you're going to do it, if you're going to plan, if you're interested in it and you have a tumor that looks like it's amenable to preserving the cochlear nerve or the eighth nerve, then you can definitely do it at the same time. If you're going to do it at the same time, then you have to do that's the translab approach, where they go through the back of the ear as opposed to retrosigmoid or middle fossa, and you have to be pretty confident that you're preserving the eighth or the cochlear nerve. Otherwise, the implant is not going to work. The best scenario is when you're doing it at the same time. The best scenario, or if you have to go back in. With the person who did the initial operation. So if you have surgery with one group and then years later you're interested in an implant, it's very tough to know what's going on with that nerve, especially in the case of a larger tumor. So it usually requires a good amount of upfront coordination and really ideal circumstances. It's not for every person.
Okay. Last couple of questions here. There's a patient who is 23 months out from retrosigmoid surgery for a 3.5 centimeter acoustic neuroma. They have lots of swallow and cough issues. They had a vocal cord implant that helped, but the vagus nerve is damaged. They had low blood pressure before surgery. Now it runs high. They had no idea the vagus nerve had to do with heart rate. Could my damaged vagus nerve be affecting my blood pressure?
Yeah, I mean, that's a little bit along the lines of what we were discussing earlier. 3.5 centimeter, again, that's a pretty large tumor that unfortunately probably was abutting these lower cranial nerves. So it sounds like this patient underwent pretty difficult recovery from that. And yes, unfortunately, that's the issue with the vagus nerve, right? It's like it innervates so many things, it does so many things in your body. And in fact, one of those things can be heart rate and blood pressure control through the autonomic nervous system. So luckily you have two of them, but unfortunately, yes, I mean, having injury to one of your vagal nerves can lead to these issues. I mean, obviously that's a little outside the area of expertise for a neurologist. You would probably really want to be working with internists or cardiologists on certain medications that can be given in patients with autonomic dysfunction. It could be managed to some degree.
Okay. Last question. We have a patient who is 6 months post-surgery. Her face feels very bruised to the touch in certain places and wonders what is happening underneath.
I could briefly take that again as well. It's just, it sounds to me like maybe this patient's having some form of trigeminal dysfunction, potentially. I mean, again, I'm not sure how big the surgery, the tumor was, etc. But like I mentioned in the talk, having paresthesias means essentially having abnormal sensations. So not necessarily pain always, but sometimes it could be just discomfort, like swelling sensation, tingling, etc. So it's possible that that's what they're experiencing. Unfortunately, there's not too many options for managing that kind of issue, more so if somebody's having like acute pain.
Okay. Well, that was our last question. We're coming up on time here. Thank you so much. That was a comprehensive 1 hour. You covered a lot of areas, and you could tell by all the questions that came in, they were all over the board, which is always a great sign. So thank you all from Mount Sinai. You folks are an expert team, and you do so much with us from webinars and patient support groups and our notes newsletter, things like that. We really do appreciate how you're helping patients. So especially for ANAwareness Week. So thank you so much, and everyone watching.
And the Acoustic Neuroma Association and all our patients and listeners, really, we owe it to them. We always want to keep getting better, and thanks a lot. Thank you.
We appreciate that. You all have a great day. Thank you.
Thanks for having us.